Well, the term we use for a dizzy spell or blackout is syncope, and we have to be first of all clear about what that means. So syncope in medical terms, my understanding is a complete loss of consciousness, normally due to a loss in cardiac output, and that's either due to a loss of blood pressure or heart rate. What's key is a history, because of course many patients come to general practice and to secondary care with faints and funny dizzy spells. And for me, the key thing is to establish that true syncope has occurred, and also to go through the history in great detail. So the most important is to separate syncope, which I would term situational, which could be explicable by a trigger, for example, excess alcohol ingestion, for example, someone who's dehydrated for a prolonged period of time, or perhaps if it's related to a drug, for example, taking GTN sublingual, which is a common cause of syncope, excessive diuretic use, or any vasodilator drugs. But having excluded situational syncope, the red flags which, with respect to history, are syncope, particularly on exertion, related to swimming, for example, syncope which occurs at rest, and syncope which can be triggered by arousal related to loud sounds, and that may implicate an underlying genetic long QT syndrome as a causal factor in someone who has syncope related to sound. It's important from the history to also think, with respect to risk assessment, about the duration of syncope. If a patient has prolonged loss of consciousness, if the syncope is associated with marked autonomic features, those are high-risk symptoms. And also it's important to distinguish syncope related through a cardiac cause due to loss of blood pressure and heart rate from potentially epilepsy as a differential diagnosis. And the hallmarks which differentiate cardiogenic syncope from epilepsy are, in particular, rapid recovery after syncope. If there's a witness, to look for the patient being flushed upon recovery, and the absence of a prolonged post-ictal phase, and the absence of specific features of epilepsy, which would include particularly localized seizure activity. Tongue biting and incontinence, unfortunately, does not differentiate between the two. Typically, the approach to examination of a patient with syncope is initially to measure the pulse, to assess the volume and character, and particularly assess for atrial fibrillation, which would be a completely irregular pulse, which may well be a cause of the syncope in an older patient. Next, to measure lying and standing blood pressure, and it's very important to measure lying and standing blood pressure at 0 and 2 minutes apart, to ensure there's an adequate assessment of postural hypotension. Next, to assess the carotid, specifically for carotid bruits, in case carotid insufficiency is a cause for syncope. Finally, it's important to auscultate the chest, and in particular in the elderly, to listen for an aortic stenotic murmur, an ejection systolic murmur which may be evident over the aortic area, which maybe suggest hemodynamically significant aortic stenosis in an elderly patient presenting with syncope. So with respect to investigation, and I think if we separate that into what can be done through primary care, if a patient has red flag symptoms, then I think it would be very reasonable to do a 12-lead ECG. Ensure that's done properly and interpreted adequately. It's worthwhile repeating the ECG as well, particularly if one is uncertain about the ECG diagnosis. Secondly, if you have access, a 24-hour ECG monitor is a very reasonable next step. But I don't think everyone who has a completely normal ECG necessarily needs that. It may be better to do more prolonged monitoring in secondary care, even to consider an implantable loop recorder, which is something we can do in secondary care. Echocardiography as a test for a patient with syncope is really only indicated if there is an ECG abnormality suggesting structural heart disease, but once again, that may be something that GPs can access through a direct access test through their local hospital. So in summary, syncope is common and the history is really vital, and the key things to take from the history are particularly exertional syncope, syncope which has perhaps occurred with exercise such as swimming, syncope which has occurred at rest without warning, and which is associated with prolonged loss of consciousness and hemodynamic upset. That syncope, which is non-situational, should be investigated. Remember to think about the possibility of aortic stenosis in the elderly, do lying and standing blood pressure properly, and think about atrial fibrillation, which is a common diagnosis which can be manifest by an irregular pulse and doing a 12-lead ECG. Do refer patients with red flag symptoms, so non-situational syncope, prolonged loss of consciousness, particularly with injury, to secondary care for specialist assessment.